Good morning, everybody. This is Dr. Karunya. I'm an associate professor in the Department of Radiology, working with Sri Lakshmi Institute of Medical Sciences. Today, we want to talk about a lot of basic radiology. Okay, it'll be like a question and answer session. I want you to all to identify what is this blue structure that we see in this image. The one on the right is the liver, and the one on the left is the spleen. Um, we all we all know that the liver is a triangular wedge-shaped structure which lies between the diaphragm and the right upper quadrant of the abdominal cavity. It is also in close approximation with the diaphragm. It is covered by the costal cartilages. What about these structures which are parallel to the vertebra and the lower thoracic and the upper lumbar levels? It should be the kidneys. As we all know that the kidneys are retroperitoneal organs. Most of the time it is obscured by bowel gas. It is usually oriented parallel to the psoas muscles. What is this yellow arrow demarcate? See, we can see that it is a stomach gas that we are seeing here. Coming to the explanation, stomach lies between the esophagus and the duodenum in the upper abdomen. It lies on the left side of the abdominal cavity, caudal to the left dome of the diaphragm. What is this structure? So this is the hepatic flexure. The hepatic flexure marks the junction of the ascending and the descending colon, and it is located in the right upper quadrant, just below the liver. What structure is represented by these arrows? As we've already seen in a few slides before that, we had seen the kidneys which are parallel to the vertebra. There we had discussed about the psoas muscle. Yes, this is an image of the right psoas muscle. So yes, it is a long fusiform muscle that is located on the side of the lumbar region of the vertebral column and brim of the lesser pelvis. It lies parallel to the long axis of the kidneys. It extends from the T12 to L5 vertebral levels. See, this is a pelvic radiograph. So let's see if you were able to identify what these structures are. So it cannot, yes, the sacrum is not there, but the structure here is the urinary bladder. You're all right. So it is seen as a rounded soft tissue mass in the mid pelvic cavity. It has a posterior base, anterior apex, and two inferior lateral surfaces. Both ureters enter the bladder at the level of the trigones. This is a chest radiograph. Here we have an abnormality. I want you all to take a keen look, as this is the most common presentation in the casualty when you are all working as the casualty medical officers. The option A is pneumothorax, B pneumoperitoneum, pleural effusion, and normal chest radiograph. I have already hinted you that it is not normal, so it should be the first three options. Coming to the pneumothorax is the lucent area which we see in the thorax, so we can rule out pneumothorax. Yes, this is the case of pneumoperitoneum. Pneumoperitoneum is free air within the peritoneal cavity. The common causes of pneumoperitoneum are upper peptic ulcer disease, bowel obstruction, necrotizing enterocolitis, and ischemic bowel. Coming here, what is the best view for detecting pneumoperitoneum? We had already seen that in the previous case, can it be an abdominal erect, chest supine, chest erect, or an abdominal supine? It's a erect chest. As we all know that it is the most sensitive plane radiograph for the detection of intraperitoneal gas. In an erect position, we know that gas, comes in to the topmost available part. So even a small amount of free intraperitoneal air can be identified in this erect chest radiograph. Here, what is this abnormality given? Can it be renal calculi, polycystic kidneys, gallstones, and pancreatic calcification? This is, as we know that liver lies here. This is the area where GP is usually seen. This is a case where it is fully packed with gallstones. Gallstones are opaque in 50 to 20% of the cases. They usually have a laminated appearance. And for this condition, we usually have this 5Fs where it is fair, 40, female, fertile, and fat. Can you all identify this pathology? Can it be medullary spongy kidney, polycystic kidneys, stagnant calculus, or the adrenal calcification? Yes, it is a case of stagnant calculus. They are nothing but renal calculi that obtain their characteristic shape by casting a renal pelvis calculus, thus resembling the horns of a stag. See, this is an image showing a stag horn, where we can see that it's all this. It has these all branching patterns. This is a gross image of a stag horn calculus, but this is how we see it on a radiograph. Coming to this X-ray, what is obvious in this X-ray? Is it a barium in the stomach? Is it calcified lymph nodes, pancreatic calcification, or left kidney stones? Whenever you see an X-ray, you should first identify the normal structure at that level. So when we come here, so it should be the pancreas. So if you relate that, then it should be this pancreatic calcification. So it is classically in the transpyloric plane. The most common is chronic pancreatitis. Pancreatic tumors like islet cell tumors may also have calcifications. What abnormality is noted in this X-ray? Um, the options are dilated loops of small bowel, dilated loops of large bowel, dilated stomach, normal, and X-ray. We all know it's not normal, not a dilated stomach, so it should be dilated small or large bowel loop. This is the case of dilated large bowel loop. Large bowel loops are identified on an X-ray as being large in caliber compared to the small loops. They have these horstrations, which are these incomplete folds as compared to the small bowel, which have these valvular conjunctivitis, which have these complete folds. What term is used to describe this abnormality? Is it a football sign, thumb printing sign, coiled spring appearance, or a double wall sign? Here, this is a typical coiled spring appearance of a small bowel obstruction. We all see that there are multiple loops of small bowel here. Compared to a large bowel, we can see that these valvular conjunctivitis are there throughout the pattern. This is indicative of an acute dynamic small bowel obstruction. I just wanted to give you a brief about the small and large bowel obstruction. Coming to the small bowel obstruction, it has a central location, whereas the large bowel has a peripheral location. The hostal folds are absent in a small bowel obstruction, whereas the hostal markings are typical feature of a large bowel obstruction. They don't extend from wall to wall, whereas we have this valvular conjunctivitis, where it is typical of a small intestine, especially in the jejunum. They extend from wall to wall. The maximum diameter should be less than 3 centimeter in a small bowel and less than 6 centimeter in a large bowel. If it exceeds this, then we are considering a large or a small bowel pathology. This is again the same image that we had seen earlier. I just wanted you to see all the points that we had discussed. What abnormality is shown in this image? There are multiple air pockets with air fluid levels. It is multiple air fluid levels which signify intestinal obstruction. See, if it is more than 2.5 centimeter in length, it is very significant. Again, it is seen in an erect X-ray, erect abdomen X-ray. This is a case of a newborn with acute respiratory distress, tachypnea, decreased breath sounds on the right side. So what is this condition called? Can you see that there is like lucency here, extending to the left hemithorax. So the options are pneumothorax, diaphragmatic hernia, small bowel obstruction, acute respiratory distress syndrome. This is a case of diaphragmatic hernia. It is typical presentation of this case is difficulty in breathing, bowel sounds in the chest, abnormal chest movement, absent breath sounds on the side of the chest, flat concave abdomen. Coming to this, the baby had a bilious vomiting. What would be your diagnosis? Can it be pyloric stenosis, duodenal atresia, infiltratinus, and esophageal atresia? It is a case of duodenal atresia. The patient is a newborn and presents with bilious vomiting. The sign we see in this chest abdomen radiograph is a double bubble sign. This is again a case of a newborn with excessive frothing in the mouth. Ryl's tube could not be passed. What would be your diagnosis? This is, can it be a duodenal atresia, pyloric stenosis, esophageal atresia, or tetralogy of Fallot? It is a case of esophageal atresia. As we can see that the abdomen is gasless. We usually see the abdominal gas in a normal radiograph. This is the most commonly seen in the newborn. Esophageal atresia commonly occurs at the fourth week of gestation. If the feeding tube is inserted, it shows a looping of the tube, as we can see in this case. The tube is looped back. Coming to this, what is this condition in this given X-ray? Can it be gastrocystis, omphalocele, inguinal hernia, or ectopic vesicle? The given condition is omphalocele. Congenital midline abdominal defect, you can see here, which is protruding on the right side of the abdominal cavity. The defect through which liver bowel herniate covered with the peritoneum and amnion. It can be associated, no, it is always associated with Turner's, Klinefelter's, Pathology of Cantrell, and cleft palate. Identify the pathology. This is a classic coffee bean appearance. All of you would know this. Yes, it is a case of sigmoid volvulus. It is a cause of large bowel obstruction and occurs when the sigmoid colon twists on the sigmoid mesocolon. Sigmoid volvulus is differentiated from cecal volvulus by a ostial wall at the end of the with the lower end pointing towards the pelvis. This is a classic appearance, as we all see that the arrows are all pointing towards the pelvis, which is marked by the star. What abnormality is given in this X-ray? Can it be prostatic calcification, fibroid uterus, bladder calculus, or calcified lymph nodes? As I always say that you should identify the normal structures here. Once you've done that, then you can come to the diagnosis. It is a case of bladder calculus. The previous was multiple bladder cal, but this is a large cal which has the laminated appearance. Patient usually presents with pain, hematuria, signs of infection, or can also be asymptomatic. The most common cause for vesical cal is bladder outlet obstruction, cystoscopy, and a neurogenic bladder. What is the name of this study that we see here? Is it a barium mean, barium swallow, barium enema, or intravenous urograph? It is a case of barium swallow. It is a dedicated test for the study of pharynx, esophagus, and proximal stomach, and can be used as either in single or double contrast study. The most common indication for this study is dysphagia. The other indications are persistent vomiting and GERD, assessment of hiatus hernia, or fistulas. What is this study? Can it be double contrast barium swallow, barium mean, barium enema, single contrast barium swallow? It is a single contrast barium swallow. Barium meal, sorry, as it involves all the small vowel. So barium meal are performed to evaluate the lower esophagus, stomach, and the first part of duodenum. As we can see that we can see the entire stomach, the fundus, the body, the pylorus, the first part of duodenum, second part of duodenum, and we can also see areas of jejunum here. What is this study? So again, this is a pelvic X-ray, so it should be some pelvic organ. Can it be cystography, hysterosalpingography, retrograde urography, or intravenous urography? This is a case of hysterosalpingography. This is a fluoroscopic examination done to normally visualize the uterus and the fallopian tubes. The most common indication for this study is infertility, where we usually assess the uterine pathologies or the tubal patencies. The contrast used is iodinated contrast, which is water soluble. The normal uterus is usually triangular in shape. Then we see these all thin tubes on both sides with the peritoneal spill, that is the spill of the dye, which has been marked. So what is this study? Is it percutaneous nephrography, retrograde urography, intravenous urography, or hysterosalpingography? Now, since we have already done hysterosalpingography, we can rule that out. So this is an image of intravenous urography. So yes, as we all marked it as, one is the left ureter, two is the left collecting system of the kidney, three is the bladder, four the collecting system of the right kidney, five is the L4 level vertebra. What is this study? Can it be antegrade urethroplasty, micturating cystourethroplasty, retrograde plierography, or percutaneous nephrography? The special investigation shown here is the ascending urethroplasty, radiographic study of the urethra using iodinate contrast. It is especially carried out to visualize the anterourethral abnormalities. Indication: urethral diverticular stricture, foreign body, or any obstructions in the urethra. What is this abnormality called? Is it small bowel obstruction, intussusception, volvulus, or small bowel carcinoma? It is a case of intussusception. The sign we saw is known as the claw sign. As we can see the reference image, it is beautifully seen. It is an important cause of acute abdomen in children. Abdominal pain, vomiting, right upper quadrant mass with red currant jelly stool are the classical findings of a intussusception. Coming to this, patients with complaint of low back pain, identify the pathology here. It is a paraspinal soft tissue calcification or vertebral erosion, abdominal aortic aneurysm, intervertebral disc space reduction. It is a case of focal dilatation of the abdominal aorta, that is 50% greater than the proximal normal segment, which is less than 3 centimeters in maximum diameter. Most common symptoms, unless they leak, are rupture, and therefore diagnosed incidentally when the abdomen is imaged for other indications. Unruptured aneurysms may commonly cause abdominal or back pain, or pulsatile mass if they are large. Unruptured aneurysms are commonly or uncommonly cause for abdominal or back pain or pulsatile mass if they're large. Okay, what is this sign called? Is it a string sign, apple core appearance, claw sign, bird beak sign? We all have seen a claw sign. So this is a case of apple core sign. This is most commonly associated with constriction of the lumen of the colon by stenosing annular colorectal cancer. Other causes are Crohn's disease, chronic ulcerative colitis, and ischemic colitis. In this condition, what is this abnormality found? Crohn's, ulcerative colitis, pseudomembranous colitis, familial polyposis. Here we can see that it is a barium enema, where we don't see any pattern at all. So this is a case of ulcerative colitis. There's complete loss of postural markings. The organ appears smooth walled and cylindrical. What is this condition in this X-ray? So is it a gastric ulcer, gastric hypertrophy, trichobizar, or a gastric carcinoma? This is a case of trichobizar. Trichobizar are again commonly seen. A trichobizar is a mass of undigested hair within the gastrointestinal tract. Trichobiza are often associated with trichotillomania or trichophagia, hair swallowing. This is a gross image of trichobiza, whereas this is the barium swallow image. What disease is suspected in this barium study? Is it a volvulus, Hirschsprung's disease, colonic stricture, or intussusception? It is a case of Hirschsprung's disease. It is also called congenital megacolon. Most common cause of neonatal colonic obstruction. It is usually failure to pass meconium in the first 1 to 2 days after birth. The affected bowel is smaller in caliber compared to the normal bowel. As you can see here, there's a narrow segment, whereas the normal is the dilated. That's how a normal bowel appears. The patient with dysphagia, in what condition is this abnormality found? Is it esophageal malignancy, esophageal varices, achalasia, esophageal spasm? It is a case of achalasia cardia. It shows a characteristic bird-beak appearance. It is due to impaired relaxation of the lower esophageal sphincter. It involves a short segment, which is usually less than 3.5 centimeter of distal esophagus. There are two respective images which show that the bird beak sign of achalasia. This is also a bird with a beak. It is a classical case of achalasia cardia. What is this abnormality noted in the IVU study? We had seen similar images in our previous slides. Is it a case of renal calcification, hydronephrosis, hydroureteronephrosis, or a renal carcinoma? Here, this is a right-sided grade 3 hydronephrosis. We don't see the ureter here on the right side, whereas the left side we can see the normal collecting system, the ureter and the bladder, which is partially filled. This is how normal kidney and the collecting system appears. When there's mild or grade 1 hydronephrosis, this is how the appearance is, moderate to severe levels. What is this abnormality seen in this image? Can it be a TB bladder, CA bladder, neurogenic bladder, or bladder stones? This is a case of neurogenic bladder. Neurogenic bladder is a term applied to for dysfunctional urinary bladder. This has a classic Christmas tree appearance or a pine cone bladder in the cystogram. It is seen in severe neurogenic bladder with increased spindle tone. This is usually seen in the worst case scenario. Thank you all. If you have any doubts, kindly let me know. Thank you.